Now I'll move to Dr. Panwar, who's one of our stars. Dr. Panwar is a general surgeon by training who graduated from our program several years ago and then completed a fellowship in the head and neck surgical oncology Creighton Fellowship at Methodist Hospital and has been an outstanding member of the department. He has distinguished himself regionally and nationally through the various professional society throughout his contribution and publications and clinical trials as well. He was the past president of the Nebraska chapter of the American College of Surgeons and also the program manager of several of the head and neck societies as well. Dr. Panwar continues to be an outstanding and effective mentor to several of our learners, students, and residents here in the program. And as we all know, this rotation is one of the most outstanding and highly sought after rotations, and we consider it one of the best and look forward to continue this relationship with our partners at Methodist Hospital. And lastly, 2 years ago, I believe, Dr. Panwar, you became a member of the Society of University Surgeons, which is one of the premier societies, and it's a well-deserved honor. Dr. Panwar is going to talk today about risk savvy, updates on management of indeterminate thyroid nodule. Dr. Panwar, welcome.
Can you guys hear me okay? All right. Well, thank you again. I appreciate all the kind words and the support that the department and the department leadership offers our team and the relationship that we have with the residents and the hard work that the residents provide in the shared service of our patients. So with that note of gratitude, I think many of you know me, but there are obviously new additions to our department here. My name is Aru Panwar. I'm an associate professor in surgery, and my primary practice focus is on head and neck surgery and oncology. I try to choose topics for grand rounds whenever I'm invited here to have overlap with a general surgery practice and a general surgery learning focus. If you are a general surgeon anywhere in the United States or across the world, you may encounter clinical scenarios or concepts that we would be talking about today. If you subspecialize as a head neck surgeon, as an endocrine surgeon, you'll see this very, very commonly, almost on a daily basis. And even if you are not in an area where you're dealing with thyroid pathology on a daily basis, as a surgeon, you will provide counsel to lots of family members, other clinicians, and there are concepts about levels of certainty, how to manage risk and uncertainty in clinical care that are applicable to all of our practices everywhere. So we're talking about updates on management regarding indeterminate thyroid nodules. Is there a direction to point this or? Oh, it's just a lag. Okay. I have no financial disclosures. None of the products or platforms that I mentioned today have any commercial relationship with me or my organization. We will be talking about some investigational only test platforms, which will be clearly identified. I have some uncompensated leadership service roles that bear mentioning. I'm an associate editor for our White Journal. I also chair the American Head and Neck Society Behavioral Health Task Force. We're going to talk about the updated Bethesda classification scheme for thyroid cytopathology. So if you do an FNA for a thyroid nodule, a fine needle aspiration to detect its clinical behavior or advise your patients about what should be done, it has to follow a specific pattern of reporting, and that's the Bethesda classification. We'll identify what those classes mean in terms of risk estimation. If somebody says Bethesda 1, 2, 3, 4, 5, or whatever, or 6, what is the risk of malignancy associated with each of those, because that's how you counsel your patients. We'll describe what molecular profiling or genetic classifier tests mean and how they are applicable and in what categories. And then we'll use some case-based scenarios to appropriately consider employing molecular or genetic profiling for surgical decision-making. As most of you would know, thyroid cancer incidence is rising in the United States. And this graph, for example, tracks some of this rise between 1975 to 2009. However, despite the elevations in the incidence, the mortality is exceedingly low. So generally, for patients with thyroid malignancy, the prognosis is favorable. And this is primarily because the bulk of disease that, or the burden of disease is on account of well-differentiated thyroid cancer, and amongst that, primarily papillary thyroid carcinoma. The question is, why is the incidence rising? And there's a lot of debate about it, which remains yet to be settled. Is it because there are environmental exposures that are newer in our communities that may be leading to these papillary thyroid cancers that are more commonly being noticed in our patients? Or are these primarily incidentalomas because we have a lot more imaging modality being used as part of clinical practice? People get carotid ultrasound and a nodule is seen incidentally. They get lung nodule screening because of previous history of smoking, and because it overlaps with the neck, it is not uncommon to see thyroid nodules that are incidentally discovered, which are otherwise asymptomatic and therefore labeled as incidentalomas in a parallel. The overall mortality is low for most of the thyroid cancers. Behavior is indolent, and there is greater desire for personalization. For a vast majority of patients that we see in the clinic, they have asymptomatic thyroid masses. They don't have swallowing issues. They don't have voice problems. They don't have a lateral neck mass. They are not having hemoptysis or hematemesis. That's exceedingly rare. Most patients come to us in our clinic, in our practice, because either they felt an asymptomatic nodule themselves or their primary care doctor felt some fullness, or that it was discovered during workup for something else. Having said so, other things can happen, including lateral neck involvement. Most patients are euthyroid. Some can be hypothyroid. A smaller proportion will be hyperthyroid. There can be infrequent symptoms relating to nerve involvement. For example, the recurrent laryngeal nerve, if it is involved by a tumor of the thyroid.
Oh, sounds good.
Is that better? Oh. Okay. So you could have symptoms relating to nerve dysfunction, the recurrent laryngeal nerve. You could have airway invasion or soft tissue invasion, which can also become issues. Whenever we talk about a thyroid patient or a patient presenting with a thyroid nodule, we want to do the general history and physical. This is for the medical students, but we focus on risk factors. Has this person had low-dose radiation exposure? Do they have a strong family history of thyroid malignancies? Many patients now have a variety of platforms that they have submitted their genetic material to, and they may have knowledge about genetic mutations or have undergone genetic counseling for other unrelated malignancies or conditions. If that information is available, we factor that in our decision making. We do a careful physical examination that focuses not just on the thyroid gland, but the regional lymph node basins and the cranial nerve examination. So patients who have those kinds of obvious problems, and you have a big lump growing out of your neck, or you have a vocal cord paralysis in the setting of a suspicious thyroid nodule, that is not the patient that we're talking about today. Those are the patients that have a high risk profile. There are clinical indicators for malignancy. There's a high pretest probability for malignancy, and surgery is likely in their future. What we're talking about are the patients who are asymptomatic, who may have an ultrasound finding and some degree of uncertainty about the clinical behavior of the thyroid nodule. The American Thyroid Association just this last week published their 2025 guidelines for thyroid malignancy management. In that publication and in the 2015 publication, this slide is perhaps one of the most important slides or schematics that they propose, which is to say that ultrasound features matter. Ultrasound features can guide us to say which patients or which nodules have higher risk for malignancy. So for example, down here, and I'll point out on the screen, I hope that the folks on Zoom can follow along, a cystic lump or a cystic nodule, no solid component, completely anechoic, completely dark. The risk of malignancy is exceedingly low, less than 1%. Those usually do not require a biopsy. Patients who have a spongy architecture, they have very low suspicion, less than 3%. We don't biopsy those nodules until a much larger threshold, even up to 2.5 centimeters. Patients who have low suspicion, solid but hyperechoic or isoechoic nodules, or predominantly cystic with small eccentric solid component, those patients may have a higher risk compared to the other varieties that we talked about. But in the grand scheme of things, it's about population risk, 5 or 10%. So again, biopsy thresholds are not as strict. Then we come down to the intermediate suspicion nodules, which are the hypoechoic, solid, regular margin, and then the high suspicion. So this is a classic appearance of a well-differentiated thyroid malignancy with microcalcification. Punctate echogenic foci are seen within the nodule. This nodule, for example, has some irregular boundaries. This one's a little bit taller than it is wide. You have cracked eggshells or an involved lymph node in the regional nodal basin. Those patients have a very high risk for malignancy in those nodules, and our risk assessment and our counseling is very different than the other end of the spectrum. So ultrasound plays a key role in determining which patients undergo fine needle aspiration. So what now? You selected a patient based on size and imaging criteria, and you wanted to do fine needle aspiration. We do that in the office with ultrasound guidance, and now we have some options that may open up. So this is the revised Bethesda classification, which standardizes the reporting for cytopathology for thyroid. This is based on fine needle aspiration and not core needle biopsies. So generally, barring specific circumstances, patients who present with a thyroid nodule should have fine needle aspiration and not a core needle biopsy unless you're looking for anaplastic thyroid cancer. There are, excuse me, 6 categories ranging from non-diagnostic to benign, atypia of undetermined significance. A key change was that there was a terminology called FLUS, follicular lesion of undetermined significance. It was always confusing to people. So they've dropped that terminology now that this is just AUS. Follicular neoplasm, again, terminology revision. It used to be follicular neoplasm or suspicious for follicular neoplasm. Again, confusing terminology, so they dropped it, and now it's just follicular neoplasm. Suspicious for malignancy, and then finally malignant. No test is perfect, therefore, there are ranges, but as you can imagine, it ranges from population-based estimates, 5 to 20% for non-diagnostic fine needle aspiration, benign, 2 to 7%. So if I have a benign result, I can reasonably reassure the patient that the likelihood of a missed diagnosis of thyroid malignancy is very low. And therefore, those patients do not require usually any intervention from our side apart from follow-up for growth of the nodule, which we will not get into the intervals of that today. If you have a malignant diagnosis, then the likelihood of a false positive is also very low. What we're focusing today is this group, which is the indeterminate cytology. The risk is somewhere between 0 and 100, and it's for AUS between 13 and 30%. So I could counsel the patient and say, well, your biopsy shows AUS findings, and there's a 13 to 30% risk, and they are concerned, understandably. But the converse could also be said, which is that you have a 70 to 87% chance that it is not cancerous. And that sometimes can put things in a different light, and they feel a little bit more reassured and kind of can talk more thoughtfully about how to assess this risk further. You could have follicular neoplasm, which is a risk of 23 to 34%, and then suspicious for malignancy, which is 67 to 83%. When we come down to the suspicious for malignancy, the risk estimate is high enough that generally most patients would benefit from surgery. The likelihood ratios for having a malignant diagnosis is high, and it is less likely that those patients in clinical practice would undertake observation alone in most circumstances. Additionally, what we're going to talk about today in terms of molecular profiling, most of the data comes from this AUS and follicular neoplasm group. So I want to put a pin in the idea that while gene expression classifier, gene sequencing, or molecular profiling is available and meaningful for all 3 of these categories, most of the data that we're talking about today comes from AUS and follicular neoplasm patients. And that while insurers, including Medicare, would pay for suspicious for malignancy category, that in general, we don't utilize it very much in that particular category in our lived experience and our day-to-day clinical practice. So 15 to 30% of fine needle aspiration specimens can come with this indeterminate cytology, and there is the role for molecular testing to clarify the risk and to inform the patients in making thoughtful choices that they may undertake. So why should we care about it? Well, I said to this patient, there's a 13 to 30% risk of malignancy because you had AUS finding. What next? Should this person have diagnostic lobectomy, which was what we did for most of these patients until molecular profiling came about, which would risk overtreatment, which means that 13 to 30% risk of malignancy. In other words, a significant chance that many patients would not have malignancy. They would undergo an operation for no specific reason, and some of them may experience side effects or complications that may come along. So we don't want to overtreat. If we observe, then a proportion of patients may have malignancies that may grow over time or contribute to other problems like nodal metastases. And this delayed and missed diagnosis does not seem attractive to clinicians and to patients. So the role of molecular testing can sometimes clarify that issue. This testing platform is primarily based on the human genome research that was undertaken through NIH. So this is a byproduct of some of that work over the early 2000s. And for the most part, we now know about 91% of contributing genetic mutations that lead to well-differentiated thyroid cancers, papillary thyroid cancer, follicular thyroid cancer, and to a large extent, medullary thyroid cancers. These genetic mutations in RAS, BRAF, RET-PTC, PAX8, and PPAR gamma, they constitute about 70% of the burden that leads to these well-differentiated thyroid malignancies. Based on this work in 2012, NEJM, this was the landmark article by Alexander and colleagues that described the development of this 167 gene expression classifier, or GEC, which is now marketed in its later iteration as Afirma. And I mention these names because these are the names that you would see from referring providers on lab test reports. So I don't have any commercial relationship with these, but you should know what these tests are and what these tests mean and what they can tell you and what they cannot. So the advantage of this test was that it utilized the fine needle aspiration specimen for gene expression classifier testing. It allowed democratization of this lab test to not only high volume or academic centers. So somebody who was in a smaller center could do an FNA with their radiologist or in their clinical practice and send that material, expedited courier to the company, and they will run the cytology for you, and they will also do the genetic test if it is applicable. So that became really popular, particularly where high volume cytopathology consultation was not available, and that allowed them to recruit a lot of participants and have this study published and subsequently to develop their commercial platform. This test boasted of high negative predictive value for AUS and follicular neoplasm lesions, but it had a low positive predictive value. So pause here for a second and think about what those numbers mean and what those things may be affected by. You may recall from your statistical classes that predictive values are dependent on point prevalence. So if I were to use this test, let's say in a population of Hiroshima victims who have a higher incidence of thyroid malignancy, the positive predictive value may rise up because there's higher probability of thyroid malignancies in those patients for the same test. What does this test tell us? That if you have a negative predictive value of 95%, if this test is indeed negative, then it is likely true, very highly likely true, that you do not have a thyroid malignancy in the tested thyroid nodule. So this became a rule-out test of sorts, which is to say that if I had a patient who fell into that indeterminate cytology category, and if I ran this test, and that came back as negative, then we can say with high degree of confidence that this is likely a benign nodule, which can be followed with the protocols that we use for benign nodules, with maybe periodic ultrasound surveillance, clinical examination, but generally avoiding surgical therapy. So this is an example of how the initial reports would look like, and I'll show you what it has evolved to now. But it would point out where the nodule was. So this nodule was involving most of this right lobe. The cytopathology was indeterminate. Then they did the gene expression classifier, and it showed as a suspicious, which they report as risk of malignancy as 40%. So it kind of made it intuitive to assess the risk for even clinicians who may not be steeped in this literature. So it made it more accessible. Concurrent to that, other platforms started to emerge. So for example, this one is ThyGenX and Thyramir. Again, no relationship with me. And I'm showing you the variety of different ways that this same question can be answered by a variety of test platforms using differing but interrelated technologies. We utilized, for example, ThyGenX many years ago, and then moved away because of a variety of factors. But again, intuitive reporting and DNA mutational analysis with mitochondrial RNA gene expression classifier testing. So in the late 2010s, as this data matured, you would see that a lot of these tests would have a negative predictive value for AUS and follicular neoplasms, which was in the 90s, 90 percentage points. So very high negative predictive value, but the positive predictive value was variable. It could range from like 30%, for example, 38% for Afirma, to something as high as 82% for ThyGenX. So a lot of variation in the test platforms at that point in time. All of these, again, these slides will be available to you. So the goal is not to remember what specific genes are being used for each test or something of that sort. Nobody's going to test a general surgery resident about those things. The point is that there's overlap in many of these things. Some tests, for example, the Afirma tests use gene expression profile. Then there's next-gen sequencing, including genetic mutations and fusion classifiers, for example, for Thyroseq. And then there's mitochondrial RNA classifiers as well. This is a more recent article that talked about, again, negative predictive value and positive predictive value. Rosetta GX is another platform, again, for the sake of fairness and balance in my talk. For a variety of reasons, it's a less commonly used test in our community, for example. And if you receive a referral from someplace, Iowa or Nebraska, you will often see Afirma or Thyroseq. And again, the key factor to recognize is that the negative predictive value is very high. These tests have continued to evolve, and they will continue to evolve over time. Now, for example, there is product information that these companies would tout and say, we are now integrating AI models in it. Well, you got to ask what that means, and they're often fairly opaque about it. But the underlying process remains the same, which is the identification of pattern of genes or their products. So now we moved away more recently from the gene expression classifier, and the product that will be available is gene sequencing classifier. That's what we're using now. And Thyroseq has moved on to Thyroseq version 3. And what you would see is that the negative predictive value remains high, still in the 90s, but the positive predictive value from Afirma GEC to now GSC has risen to 60%. Similarly, Thyroseq version 2 versus version 3, positive predictive value has also risen. So these tests continue to improve, and while they're dependent on the clinician's ability to apply them in the right context, in the right hands, they can be fairly powerful in providing reassurance to patients or to guide appropriate surgical therapy. So this is an example of a demonstrative slide for Afirma's report. So this describes where it came from, who the patient is, when it was received. Initially, when they had cytology, so they would kind of verify that the cytology was indeed indeterminate and advise you if the use is inappropriate. The classifier was suspicious. They do a genetic expression atlas, and there's a KRAS mutation that's described there. And then they tested for the other common variants of BRAF V600E, and then RET PTC1 and RET PTC3, and then looking for medullary thyroid cancers and parathyroid. They actually have 7 genes within the profile that can also help identify a parathyroid. So it is not common, but you could have an intrathyroidal parathyroid that looks like a nodule. And if it shows compatibility with that, it may alert you that this may actually be a parathyroid tissue and rather not a thyroid nodule. They identified that the risk of malignancy is 50%. So even chance in this person to kind of have malignancy in that nodule. And then they have started to validate some additional data. And this is not currently something that FDA has approved to make recommendations on a day-to-day basis, but they're starting to look at genetic profile that may help guide whether or not there are problems with local regional invasion or aggressiveness. So for example, they're talking about extrathyroidal extension. Is it low risk or is it higher risk? Is there baseline or higher risk for nodal metastases, or is there low risk for nodal metastases? This part, there needs to be a lot more work before we would start incorporating that on our day-to-day decision making. But it's important to know that these are the next frontiers in terms of how this technology may evolve. So how does this translate to the real world in good and bad ways? So let's kind of delve into that. So this is from McGill University. As you know, the Canadian healthcare system has some overlap in its characteristics with the United States, but then there are some other things that distinguish it in how patients receive care, who provides the financial support, what the wait times are, and what resources are available. So these clinicians were interested in identifying the value of gene sequencing or molecular profiling in identifying the right patients who should go to the operating room and reducing the number of patients who would end up in the OR. You take their thyroid out and the result comes back as benign. So they had a pre-pilot and a post-pilot phase. In between those two phases, they implemented a version of molecular testing. And what they found was that the proportion of patients who were being operated upon who had malignancy increased. In other words, the number of patients who underwent an operation in their hands or in their team who ended up with a benign test result ultimately, who could have theoretically been observed with sonographic surveillance, they were benefiting those patients by appropriately selecting those patients. So that they felt helped streamline their OR scheduling and reduce the burden on a limited resource of OR availability and surgical time. This particular paper talks about what happens to the benign classified nodules. So I get a test and I have an indeterminate nodule. I say 13 to 30% risk or 23 to 34% risk based on Bethesda 3 or 4 respectively. And then I submit it for genetic testing or molecular profiling. And it says, it's benign, let's watch it. What's the chance that it grows over the course of follow-up that we end up receiving some sort of surgical intervention? So in this study, it was about 22%. And that number is fairly within what is variably reported in literature for benign nodules. So that tells you that a vast majority of nodules that were classified as benign still could be monitored without any interval growth. And it's important to note that we have to think about what's the follow-up duration. And in this study, the follow-up duration was up to 3 years. So if one of you guys as a young person were to be diagnosed with thyroid nodules, you want to see longer term follow-up. So that's one caveat that I would introduce. You're not looking for 3 years of nodule growth-free survival. You're looking for a much longer runway ahead of you. So with that caveat, some limited information. Does it reassure patients? So somebody who has a thyroid nodule, you told them that there's a 13 to 30% risk of malignancy. Are they going to be anxious or are they not going to be anxious? Will they have any quality of life detriments if you were to observe them instead of taking out their thyroid? Some patients, when I talk to them, they say, Doc, whatever you tell me, I want this now out of my neck. I'll take my thyroid medication if I need to, and I just want you to take it out. I'm not going to be watching this. This is a ticking time bomb, they say. That's a little dramatic. We don't need to do that. But the point is, can this be reassuring? So in this study, what they looked at was they used a ThyPro 39 quality of life scale, and they found that patients who had benign GSC results had preserved quality of life. So it can be reassuring to patients and can meaningfully impact their quality of life. All of this means that there's a proliferation of this data through a variety of media platforms, general awareness amongst patients and consumers, so to speak. I don't like the term consumer. It kind of commodifies the thing, but it's rising. And this is even before AI answers became available. So a patient that you may sit across today and say you have an indeterminate thyroid nodule, it is very likely that their family members who sitting there is putting it into Gemini or ChatGPT and saying, what is my next step? Even before the doctor tells them the next step. And it would very likely be that it may come up with an answer saying, you need to have an Afirma or a Thygenix or a Thyramir or Thyroseq or Rosetta or whatever else, right? Again, context matters, but patients are aware of these things and they will ask you about this stuff. And there would be choices, and sometimes patients have the choice paradox where we present them with the options and we say, you know, you have the option of observation or doing a genetic test or, you know, considering surgery. And choice paradox can lead to delay in care or sometimes dissatisfaction with care. On the flip side, physicians want to be right in their decision making. We want to do right by our patients. We always say this all the time in the OR, measure twice, cut once. So can we get more data that may help our surgical decision making? So that's important and part of our ethos on a day-to-day basis. But part of our ethos is also that we are old dogs often, and it's hard for health systems to learn new tricks. So when we employ new technology or new information systems in our healthcare systems, not only as physicians, but as a healthcare system level, we got to think about what that implementation means for us and for our patients and for the healthcare economics, for our system and the broader society. And I say that because oftentimes data may be available. In our previous hour, we heard about how residents could be tracked in NISQIP. And one logical question to ask would be, what meaningful information can we or can we not glean from that data that is being collected? Because oftentimes healthcare outcomes are not the end product of one person's effort. It is a systems-based process. When there's a retained instrument or when there's a poor outcome or when there's a good outcome, it is not because of one particular element. It's a systems-based approach. So can we teach our healthcare systems new tricks? And then we all want to use ChatGPT for everything these days. You know, we see today I'm going to talk about genome profiling and molecular profiling of thyroid nodules, and it may look like everything later today is going to seem like it's going to be the perfect candidate for that. So if you have a hammer, everything looks like a nail. So how do we select the right circumstances? And that's important. So you have to have discretion. You're still a clinician. You have to make that judgment call, looking at the patient's values, their clinical presentation, what data is available. Is the data already there that would make me operate on this person or make me observe this person? If I have a 95-year-old person whose ECOG performance status is 3, and they come up in a wheelchair with 6 liters of oxygen flowing, and they have terminal illness, that person, no matter what you tell me from a Thygenix or Thyramir or Afirma or anything else, that is not the right person to operate. They are more likely to die of other reasons than of an indolent, well-differentiated thyroid malignancy. So is the clinical data already available? If I have somebody who has Graves' disease or toxic multinodular goiter, who is a candidate for surgical intervention to alleviate that disease pathology, that gene expression classifier or molecular profiling is not going to be helpful. If my cytology is determinant, it says benign or it is malignant, I may already have my answer, right? If I am operating on somebody who presents to me with compressive symptoms and a large goiter, again, the data is already there. If I have a nodule on the ultrasound that looks very concerning to me, and I am so anxious, or my patient is so anxious that our anxieties are not going to prevent us from doing an operation, we're not going to believe what test we learn about, well, then why do we do that test? The test is only valuable if you can act on it, right? So there is the risk for inappropriate use. So for example, in this particular study published in JAMA Oro, after gene expression classifier became available to a group of surgeons, there were patients who underwent that test when they already had determinative cytology. They already had a benign or a malignant diagnosis, but yet a test that is designed to classify something into malignant or benign was then used. So that was a wasted effort. There were clinical determinants for surgery in about half of their patients. And then in many patients, the test results increased anxiety for the healthcare team or the patient, and these clinicians determined that some patients were over-treated. What about, we all hear about, oh, this is a clinical trial that we find results from. Great. Is this applicable to my patient? What's the real-world applicability? What is the post-market surveillance data saying? Do the results of the validation study and a clinical trial mimic what experiences we may see in the real world? So this particular paper looks at comparison of the pooled analysis for data from real-world studies versus the validation study from Alexander and colleagues in 2012. And what they found was that the bounds of uncertainty, you guys remember perhaps from my previous talks or from your other exposures to statistical analysis, we think about confidence intervals or bounds of variability or variation that we permit in a study, the degree of uncertainty. So Alexander and colleagues' data is presented here in the orange dot with the red arrow, and the gray zone represents the variability that's permissible based on that data. And what you would see is that for benign call rate proportions and for positive predictive values, the real world data, the average either lies outside of that gray band or right on the edge of it. So experiences don't always match, and part of that is patient selection. Which patients are we using it on? What is the patient population? What is the point prevalence? And the conditions of the experiment are not readily replicated in the real world. I mentioned this before, knowing who your patient population is. Are you applying this in Omaha, Nebraska? Are you applying this in Nagasaki, Japan? Are you applying this in parts of Italy where there's a higher risk for thyroid malignancies because of clustering of certain patient populations? That matters. So if your point prevalence changes, your predictive values also change. So the same test performance, if it was to be applied to a different patient population, may not be exactly the same result. And you have to think about, are these validation studies being conducted in those disparate groups of patients? We got to think about resources, and that includes time, the cost, and logistics. When I do a fine needle aspiration in the clinic, we do 4 passes in a thyroid nodule, 25 gauge needles, ultrasound guidance, and the 3 passes, they are being sent for cytopathology, for cell block analysis, and then there's an extra pass that goes in a vial that is now banked and refrigerated. If this patient's cytology comes back as indeterminate cytology, then I already have the material for gene expression profiling or molecular profiling without having to repeat a fine needle aspiration post hoc. But my cyto tech needs to know about it, my nurse needs to know about it, the lab needs to know to send that vial. There's the refrigeration cost, right? So a systems-based approach. As opposed to somebody gets a fine needle aspiration, then a week later you find out it's indeterminate, and then you decide, I want to bring this patient back to consider fine needle aspiration again, and you're sticking them again. Both of those approaches could be argued for. We obviously prefer ours, but it requires systems-based efforts. It's a send-out test. It takes about a week to 2 weeks for it to come back. So managing patient anxiety, you won't have a result tomorrow. There's direct costs. We estimated it was $4,200 of cash pay or something some years ago, but it is not a standard thing that everybody pays the same stuff. You've heard stories where somebody gets a $10,000 bill and another person gets $500 bill, depending on their specific circumstances of insurance and such. So knowing what the implications are on the healthcare economics is important part of our stewardship as well. This study from Canada talks about a $5,000 willingness to pay threshold. This is Canadian dollars, so it doesn't mean anything. Molecular testing has 63% chance of being the more cost-effective strategy for avoiding unnecessary surgery. So they say that if you had a cost set at $5,000, that makes it worthwhile. Great, top line numbers, still a big number. $5,000 is no small money. But if you delve deeper into this paper, you have to understand how this came about. So they have a decision tree analysis, and they make some assumptions of what the costs are for various things. For example, what's the cost for following up a nodule that you don't operate on or that you don't identify with gene expression classifier testing? What is the cost of thyroid cancer follow-up? And those assumptions matter because that's how the decision tree analysis is done. So again, the applicability of the data has to be tested against your world and your lived experience. One of the assumptions that kind of caught my eye in that paper was they said the cost of following somebody with thyroid cancer for a year, 1 year follow-up, is $423 or something like that. I can tell you that if I do an ultrasound on somebody 3 months after their total thyroidectomy to establish a new baseline, the insurance billing is about that for the ultrasound alone. So that assumption doesn't track with the US healthcare system here in Omaha, Nebraska. So you have to be thoughtful about what the underlying assumptions are and the metrics are before you take it at face value. So if we were to change those assumptions, the cost can dramatically shift and the willingness to pay can change. I would also posit something else, and that comes from my lived experience when I was a medical student in India. 5,000 Canadian dollars or US dollars is a lot of money for a lot of people. But we don't think about it as much as long as insurance pays it, right? It's not coming out of my pocket and I'm already paying my insurance. Unless you don't have insurance, and then if I ask you to pay $5,000. Or if I were to fly to India and find a patient in my community where I grew up, and then $5,000 would bankrupt many families. So think about it from that perspective. And these things, this is a screenshot that I took yesterday after our endocrine conference. Reddit, my ENT offered a Afirma, pardon the spelling mistakes, it's not me posing that question, for a Bethesda 3, TIRADS 5, TIRADS is just like BIRADS for radiographic assessment, Bethesda 3 nodule. So appropriate use, I'm fine with that. Report came back three days later. I want to know how they did that. Mine don't come back in 3 days. 10 days later, my insurance denied it. So that still happens. And cue the $6,400 bill. So $6,400 being charged for this patient. That's a problem. But then somebody else's experience says, I negotiated the rate down and it was like $2,500, and if you do cash pay, it might be even lower. So these experiences can be frustrating for patients, and the variability in price creates additional uncertainty. So when you counsel patients about gene expression classifier testing, you got to make sure that you counsel them that sometimes insurance companies would deny coverage, and there may be cost that comes down to them. Most of these companies have like patient support mechanisms where they write off the cost, and they might ask you to pay a small fee. Again, not assuming what's small and what's big, but I've seen like $400 or something of that sort. So that happens sometimes, rarely still, although most insurance companies are now paying for it. So if you had to take one slide home, this would be it. I'll give you all of them, but so this is the revised categorization for Bethesda classification. Molecular analysis may be helpful in scenarios with indeterminate cytology, primarily AUS and follicular neoplasm. We have the risk estimates listed, and then the benefit is somewhat less certain, and data is a little bit more murky for suspicious for malignancy or Bethesda 5 category. So we got to choose wisely, personalization versus one size fits all. There are several good tests. I don't advocate for any particular ones. but there's no ideal test. They have all high negative predictive value, but variable positive predictive values. Look at the clinical data. Do we already have the information? Do I really need this test? How will the test alter what I do? And if it doesn't, then maybe not. Appropriate use would be an asymptomatic patient who's otherwise not bothered by any compressive symptoms, who doesn't have vocal cord paralysis, no other indications for surgery. It is indeterminate cytology, the AUS, which is Bethesda 3, and follicular neoplasm, Bethesda 4. And the patient is willing to observe when the test is negative. A patient who tells me that this test is not going to change my desire for surgery, or this test is not going to change my desire to avoid surgery, no matter what you tell me, I'm going to do what I've told you I'm going to do, then that test is not going to inform our decision-making or shared processes. It's not useful when you were going to do surgery anyways. It's not useful when you already have determinate cytology, benign versus malignant. If you have a large nodule, there can be some limitations for sampling, although this is a relatively soft contraindication. An anxious patient or an anxious physician who is not willing to look at the data and respond to it should not obtain that data because it's just more wasted money and more wasted time otherwise, right? But hopefully these data relieve anxiety and give some measure of confidence. So we're going to do some vignettes here. I'm not going to judge anybody, including residents on our service right now or recently departed residents, James. But here's a 26-year-old woman. James, I'll just point to you. No other history, incidental 1.7 centimeter thyroid nodule. FNA was inadequate. What should we do? Options up in the corner.
Are you picking on James?
Yeah.
I'd repeat it.
Okay. No molecular test. Consider repeat FNA or observation depending on patient values. Good job. I was worried for a moment that you're not talking to me. All right. Dr. Riley. 26-year-old person, same person. No other history. Incidental 1.7 centimeter thyroid nodule. FNA is benign. What should we do? Okay, so no molecular test needed. Consider observation. We already have determinative cytology, right? Good answer. You guys are doing me proud. Okay, who should we pick on? Madeline, Dr. Adams? Okay, 26-year-old woman, no other history, incidental 1.7 centimeter left thyroid nodule. Fine needle aspiration comes back as papillary thyroid carcinoma. Same patient, just a different scenario. PTC, well-differentiated thyroid cancer. What should we do? Okay. No molecular test. We already have determinative cytology, and we should consider surgery if it aligns with the patient's goals and their health. You can see that I did not want to get in the debate of total thyroidectomy versus lobectomy. That's a different conversation, but the idea is that we're doing surgery for this person as a preferred therapy. Okay. Dr. Wade. 26-year-old person, no other history, incidental 1.7 centimeter left thyroid nodule, follicular neoplasm. What Bethesda category would that be? Okay. What option should we do? I always have to talk to the patient, but yeah.
That was their shared decision making.
Okay.
You could pursue a lobectomy or molecular testing, but I would say lobectomy, traditional treatment for this.
What do you want to do? You'll do a lobectomy. Okay. So consider molecular test or diagnostic lobectomy. Both are reasonable options. But in our hands at this point in time, we mostly would steer them towards molecular testing, primarily because this nodule looks fairly innocuous, well-defined borders, has no microcalcifications. It's a person who's relatively young, and if their desire is reasonably to avoid surgery, then molecular test is a very reasonable option, but diagnostic lobectomy is very appropriate as well. Okay, who should I pick on, Dylan? Dr. Podber, you're going to be coming up soon. Okay, 26-year-old woman, Dominant left thyroid nodule. It's 4.5 centimeters in size. She has dysphagia. Pills get stuck. This is her CAT scan. This is her ultrasound. For context, for those who are not familiar with neck ultrasounds, trachea, big mass here. And again, trachea, this is midline, carotid, jugular, thyroid mass. Okay. Previous history of right thyroid lobectomy, had a small papillary thyroid cancer focus. She's been doing well. That was like 8 years ago. What should we do? Okay, what thyroidectomy? There's two options there. A total thyroidectomy, the other side was already taken out, so you can't do a total. Okay, so I'm not quite certain that it is malignant, but because the patient is symptomatic, right, and to relieve her symptoms, we think that surgery would be appropriate. A molecular test would not convince you to continue to observe this person who has documented symptoms from a compressive thyroid mass, which is pushing her windpipe to one side. You guys are rocking it out of the park. Completion thyroidectomy, other words, lobectomy for symptomatic nodule. Okay, who do you want to toss it to? Hot potato. Okay. 28-year-old male. Maybe one of you guys, did you see this person yesterday in clinic? 28-year-old male, asymptomatic, presented with right neck mass. FNA of the right neck mass was done, and it showed follicular cells on fine needle aspiration. So for context, this is a coronal view. You can see the carotid and the jugular veins partially, thyroid cartilage, airway here. You can see lots of lymph nodes in the lateral neck. You can see the thyroid mass, lymph node, jugular vein, carotid. Okay, what does the follicular cells on fine needle aspiration of the lateral neck node mean to you? What does it tell you? That's not a distant memory, hopefully not. Do thyroid follicular cells belong in lymph nodes in the lateral neck or anywhere? Okay, so what does that mean? So it's a thyroid malignancy because thyroid follicular cells should not be in the lateral neck lymph node. So what do you want to do? Remember, best option. What are you going to do after surgery for this person? Okay, so correct. So this person's likely going to get adjuvant radioactive iodine therapy. So total thyroidectomy, I didn't use the words neck dissection there, but yes, you will do a neck dissection as well. So that's what you would do. High pretest probability of malignancy due to imaging characteristics. This is a malignant thyroid mass with regional nodal metastases. Therefore, surgery is the appropriate answer. Okay. All right. So we are 5 minutes to end. So we'll conclude by saying that molecular testing for thyroid nodules are commonly employed appropriately for Bethesda 3 or 4, AUS, or follicular neoplasms. They can be used for suspicious for malignancy or Bethesda 5, but with some caution. There is high negative predictive value and variable positive predictive value. It may inform decisions to operate versus observe and the extent of initial therapy in some cases. For example, I'm kind of just thinking about a patient who has a thyroid nodule. If it were to be told to me that it's a papillary thyroid cancer, it's big enough that I will do a total thyroidectomy. So maybe that clarity can be helpful. There's evolving role of this technology. So the risk estimation for nodal involvement or locally aggressive behavior, you may have seen that experimental only portion of the AFIRMA that I was describing. So that will be validated over time and hopefully that will help. Multicentricity. If I'm concerned about doing a lobectomy for a person, what is the chance that this person has other microscopic foci of tumor in the other side of the thyroid, which I may want to preserve? And does that impact my decision making? The need for or intensity of adjuvant therapy. If you tell me that this person is higher likelihood for nodal recurrence down the line based on genetic profile, maybe I'm more likely to treat them with adjuvant therapy. And then surveillance optimization. If a tumor based on its genetic profile is less likely to loco-regionally recur or have distant metastases, maybe I don't have to bring those patients that frequently or image them that frequently compared to some others who may be at higher risk. So this technology will continue to evolve, and hopefully we'll have some more applications in the years to come. And that's all I have, and I welcome any questions that you may have.
Thanks, Dr. Panwar. Could you elaborate a little bit more on, it was like one of the last points you made about how this test might influence what surgery you're preparing for. So like what imaging characteristics are going to push you, say you have a Bethesda 4 that you're already planning to operate, planning a lobectomy, but now you might want to be saying, do I need to do a total thyroid for this person? So like what are some imaging characteristics or other characteristics that might push you to get that test in that setting?
So let's say if I have a test that has a high positive predictive value and a high negative predictive value, then it can be helpful sometimes. A negative predictive value helps me rule out malignancy. But if I can have a rule-in test, something with meaningful positive predictive value, where I can say, if this were to be told, let's say I have a nodule that's 5 centimeters in size, and most of the data about lobectomy versus total thyroidectomy comes from patients who had less than 1 centimeter tumors. And to some degree, there's some literature that's primarily retrospective that extends that limit to 4 centimeter tumors for well-differentiated papillary thyroid carcinomas. But I have a 5 centimeter tumor, and I'm kind of counseling this patient, and the patient's like, you know, we don't know for sure that this is malignant. Can we just take this out? And I know that if it comes back as papillary thyroid cancer, I would tell this patient that the literature does not validate doing lobectomy alone for this large of a tumor, and we have to go back and do a total thyroidectomy. So I have to take them back again. But if I had a positive predictive value that was high on my test, and it suggested that the risk of malignancy was substantial, then I may counsel that patient a little bit differently and say, it is not a guarantee, but there's a high chance that this is a thyroid malignancy, and therefore we should consider a total thyroidectomy at the time of surgery instead of doing a lobectomy and then coming back. So extent of surgery in that capacity. Now that's a very case-by-case basis. That is not how the test is primarily designed to be applied, but that's where we use our clinical judgment there. Does that answer your question to some degree?
Hey, Dr. Panwar, thanks for coming today. It's always a pleasure to listen to you talk about this lecture and the development of how we approach these patients. I have a question about your thoughts on the use of cell-free DNA and how that may, you know, as we're kind of progressing along in the management of these patients, if there's any applicability and further screening on some of these indeterminate nodules. Do you think that that's something that we'll do in the future, or what are your thoughts about that?
Do you have a dry erase board that I can draw on or something?
Yeah.
Okay, so anything that we're looking for screening or surveillance, we got to think about this test. Is it going to inform my decision making to prevent problems before they become meaningful to the patient in terms of symptoms or their outcomes? That's what we're thinking, right? If I do cell-free DNA of some sort for a lung cancer patient, I want to know that I can detect this sooner, and therefore I can intervene, and therefore I can improve their survival or their oncologic outcomes. Do I just touch it? Yeah. Okay. So this is non-detectable. I like this. Detectable. Non-symptom, or let's say symptom plus or minus, or incurable. Okay, I have these categories. So let's say I have a tumor that is very indolent, think prostate malignancy, or even in well-differentiated thyroid cancers, if I went to the morgue and found 100 people who died of a car crash, took out everybody's thyroid, 7 to 10% of those patients will have small indolent papillary thyroid cancers that they lived with and died with, nothing happened. So this is what happened, end of life. It's detectable here because I did the autopsy. So did this cancer matter? No. Then there were cancers that grew, they became detectable. Somebody palpated it. Your doctor was good and they felt the neck, did the examination like they're supposed to. You found it here, you intervened it here. We had a thyroid. I should be able to draw a thyroid better. And we took it out, life is good, nothing happened. Then there are patients who became detectable, became symptomatic. They have a vocal cord paralysis. That's a meaningful quality of life problem, right? I wish I had found it here and intervened it here. And then there are those that become very quickly incurable, and anaplastic thyroid cancer would be an example. So if I did cell-free DNA for a disease process that had very high incidence, relatively speaking, 7 to 10% of patient population may have some indolent papillary thyroid cancer, that was relatively indolent and usually for majority of patients did not cause any trouble, but we did cell-free DNA on them every year. Cost, time, anxiety, and overtreatment. If I were to intervene for this patient, that would be overtreatment, and some proportion of these patients will end up with a recurrent laryngeal nerve injury or hypoparathyroidism. They need thyroid medication if you did a total thyroidectomy on those patients or something like that. So you see there's a ethical and the economical aspects of cell-free DNA. So when you think about a tool, the mere detection of disease is not meaningful. It is a question of whether that actually translates to harm or benefit. Another example for this would be for these patients, let's say we were to do cell-free DNA on every single patient in a high probability scenario. Let's say cervical cancer or anal cancer among specific patient populations where that risk becomes higher because of specific sexual practice or something. So some sort of test there might be more meaningful. Again, the point prevalence becomes important. So cost and the effectiveness and the value to society, the level of anxiety, those things would be meaningful. So when everybody is excited about tests on a chip, it's yet to materialize, but there are things that are coming on. For example, there's a test called Gallery. You can order it online. You can get a blood draw at a local lab, and then they'll tell you whether you have colorectal malignancy cells floating around. But let's say you get a colonoscopy and you can't find anything because it's at the cellular level at this time. What do you do about that? Would you like to have a total colectomy? Right? And then finally, again, this is not an epidemiology class or ethics class. Other concepts have to be considered. Lead time bias. You detect some disease at an earlier stage, but their overall outcome is not any different. You just found them with lead time bias where you detected them earlier, where they end up at the same date for their death, then it's not very valuable. So these technologies need to be very thoroughly validated and then tested in real world scenarios before we readily accept them. Unfortunately, what happens is that many technologies would be translated into communities where they're not critically appraised, and everybody's ordering it or adopting the technology. Then you don't want to be an outlier, so the cat gets out of the bag. An example would be robotic surgery for certain applications that have no benefit. Okay.
For being here. It was a very educative talk. Talking about overtreatment, overdoing things, just a scenario for patients with incidentally detected thyroid nodules, suppose less than a centimeter, very small, but still has some high-risk features. Maybe you see some microcals or taller than wider, whatever. You may think that it has some high-risk features, but very small. Would you still do an FNA, or would you follow up, or there's a strict size criteria?
Again, the question is, you detected something that may or may not be problematic.
Right.
So it's a question of trying to find the benefit and avoiding harm. When we make population or public health recommendations, we make those recommendations on the greater good for the entire population, right? What's the probability of running into trouble or not? Can it be that one of those patients shows up with regional metastatic disease? Sure, it can happen. But a vast majority of the patients will have an indolent course. So there's actually clinical trials that have looked at that scenario, where a person who has a well-defined nodule within the substance of the thyroid, but was less than a centimeter in size, had microcalcifications, underwent an FNA, positive diagnosis of papillary thyroid cancer, so well-differentiated papillary thyroid cancer, in a person who was willing to undergo surveillance and see what happens. So they found that most of those patients did not have any dramatic change in their thyroid nodules over time. And the follow-up was in several years. I fail to remember if it was 4 years or 5 years. Eventually, some patients got sick and tired of the surveillance and wanted their thyroid out. A small proportion of patients had progression of disease requiring thyroid removal. But a vast majority of them continued surveillance, nothing happened. So again, the idea being that from a public policy perspective, from the perspective of probabilities, we don't generally recommend FNA for things that are less than a centimeter in size for the most part. There are exceptions to all rules, guidelines are guidelines, they're not dogma, but in general, less than a centimeter in thyroid, we generally don't biopsy those.
Okay. Thank you.
Thank you, Dr.